Hi everyone. Thank you for joining this lecture on physician well-being. This is one of a series that specifically focuses on mental health and well-being topics in physicians and medical trainees. Today we'll talk specifically about depression, and my name is Kristina Sowar. I am a psychiatrist here at the University of New Mexico. I am also a member of the team in the Office of Professional Well-being, and particularly working with graduate medical education. But I'm excited to connect with you today and talk a little bit more about this topic. So there are no relevant financial disclosures for the conversation, and I wanted to express gratitude to colleagues at the University of Pittsburgh Medical Center who have put together the Well Toolkit. This is an amazing resource of presentations, educational content, and resources for physicians, and you will see that a handful of the slides reference content. This is a great resource to check out as well. So the objectives for today's talk: first of all, we will review and define what depression is. We'll also consider the manifestations of depression in physicians specifically, and then we'll reflect upon risk factors for depression, again specifically in medical professionals, and then think about some strategies for intervention and support. So I wanted to capture the experience of depression beyond kind of the medical textbooks and think more about life experiences and some quotations that I think capture the experience of living with depression. So the first one on the left here is saying it's very hard to explain to people who have never known serious depression or anxiety the sheer continuous intensity of it. There is no off switch. Depression is feeling like you've lost something but have no clue when or where you last had it. Then one day you realize what you lost is yourself. And then finally, it's so difficult to describe depression to someone who's never been there because it's not sadness. So just to kind of transition with this, that we may all have some degree of preconceived notions about what depression means, but for each person it can be a very individualized experience. So depression is a formally recognized medical and psychiatric condition, and we know it has a multifactorial root system, so biological, genetic, psychological, and social roots. And there are a spectrum of depressive disorders. So depression can be from major depressive disorder or persistent depressive disorder. It can also be a part of a bipolar disorder. It can be seen with anxiety disorders, also the mood changes that come with having experienced trauma. And then it can also be secondary to other medical and substance use conditions. So a lot of what we talk about today is depressive symptoms, and a bit more about specific depressive disorders, but again, just to acknowledge that people can feel depressed given a multitude of different roots. Okay, so many people have studied major depressive disorder in medical school and know these symptoms pretty well, but just to review, to meet the criteria for major depressive disorder, one has to have had at least 5 of the following symptoms present in the same 2-week period. And at least one of the symptoms must be either diminished interest or pleasure in activities or depressed mood. So as you can see here, those first 2, depressed mood and anhedonia, things like weight change, appetite disturbance, sleep disturbances, either too much, too little, some degree of psychomotor agitation, kind of restlessness or retardation, feeling like you're moving through sludge, feeling fatigued, loss of energy, feelings of worthlessness, guilt, diminished ability to concentrate, and recurrent thoughts of death or suicide are all some of the symptoms of major depressive disorder. These screens may also be familiar to people working in medical settings. The PHQ-9 is an evidence-based screening tool for depression that's quite sensitive and specific. There are several versions available online, but just to reflect here that the PHQ-9 does capture the symptoms that we talked about. And so we often administer these to patients, but something that we can think about in terms of our own reflection. In terms of the epidemiology of depression, we know that many Americans and many people globally are affected to some depth or another by depression. The prevalence of depression in physicians exceeds the rates in the general population from the research that we have, suggesting somewhere around 12% of male physicians, almost 20% of female physicians, and 15 to 30% of medical trainees will meet criteria for a major depressive episode at some point during their training or career. And when we think about physicians and some of the reasons why they may have a higher risk of depression, let's acknowledge some of the unique stressors that physicians have. So we know there are the acute stressors of working in medicine. So patient illness, patient death, medical errors, insecurity about our jobs, patient and/or system dissatisfaction, fear of license restrictions or malpractice lawsuits. Those can all have a fair amount of weight and vary day to day. There are also chronic stressors. So we know many physicians struggle with unplugging from their job, being able to decompress from their workload, and also sometimes experiencing a degree of isolation professionally, including from family or from loved ones who can't always identify with the experiences. And then, of course, on the right, we know that physicians as humans are not immune to stressors that affect everyone: relationship challenges, financial issues, just concern about job and other family or interpersonal stressors. This is a study that looked at factors that were associated with increased depressive symptoms in residents, and so those are listed here. As you can see, several risk factors. Many of these make quite a bit of sense when we think about kind of connection between exhaustion and stress and depression. So burnout, social isolation, having long work hours, especially with poor sleep schedule, feeling fatigue, and then the lack of control can be a really important one. Having flexibility and schedule can go a long way for people, so the lack of control certainly can be a risk factor for depression. A history of other mental health conditions, including trauma, substance use, difficult environment in terms of feeling mistreated at work, poor experiences in a learning environment, inadequate feedback, systems-related issues in terms of prior lawsuits, or also being in an institution where there's quite a bit of pressure on achievement or research. And then again, stressors outside of work. So I think it's worth acknowledging those risk factors, right? A lot of those may be hard to change, especially in a short term, but I think help us understand why physicians carry a heavier burden in terms of their risk for developing depression. So we talked about the PHQ-9, we talked about the diagnostic criteria for depression, but let's think about often how depression can manifest from an external kind of observation for a physician. So if there are observed changes in work performance, things like changes in punctuality, including delayed response to calls, failure to complete required tasks, poor participation in work activities, isolationism, changes in professionalism, increased frequency of medical errors, those can all be red flags about something going on for the individual physician that may be depression. This is a key take-home point, that performance at work for physicians is often the last thing, though, to really be affected. Many physicians function at relatively high levels until their depression is severe. So when you start seeing impact on work performance, that can be a cue that there's fairly significant challenges going on for an individual. Other signs and symptoms would be aligned with the earlier symptoms we talked about of depression. So observed or experienced mood changes, hopelessness, irritability, guilt, anxiety, rage. People are making or experiencing thoughts like, I'm a burden to others, I feel trapped, I can't keep doing this, I don't have a reason to live. Or concerning behaviors, so recklessness, withdrawal, isolation, substance use. Again, these are all patterns that we want to watch for in terms of awareness of depression and intervention. So we've given some context about what depression is, how does depression manifest in physicians, and why are physicians at higher risk. I just wanted to spend a couple slides reflecting upon, for all of us, thinking about both our own self-care and then taking care of colleagues, that if we're seeing signs of concern in others, it's really important that we ask just to check in and see how they're doing. It can be pretty uneasy feeling to start a conversation, expressing more interpersonal concern about a physician, but it's usually met with gratitude, and here are a few suggested interventions. So instead of saying, "How are you?" things like, "You don't seem yourself. How can I help? I have to be honest, I've been concerned about you recently." Or, "What was today like for you? What brought you joy? Did anything derail you?" Just finding some different anchors to open the conversation. And once you've opened the conversation, some of these further steps can also be beneficial. Being able to validate that as physicians, we're really good at taking care of others, but it can be a challenge stepping back and taking care of ourselves. Providing information that seeking help can be confidential and it doesn't have to impact one's training or practice. And normalizing that, I've talked to someone about my own problems. I did counseling, I've been on medications, and it helped. Can also go a long way. So the last few slides here, I wanted to think about if you or if someone you care about is depressed, what are some of the important steps to take in terms of treatment and recovery? I think these two pieces are more thought-based and more kind of internal shifts, but really important. So one is being open to the awareness that we might be depressed and recognizing it. Often we push off symptoms, we may attribute them to other things, we may just keep plowing ahead and moving forward with things that we need to be doing, but actually intentionally creating space to be aware can be an important start towards making the changes we need to. The other, simultaneously, is acknowledging the stigma and the vulnerability that comes along with having a mental health or a medical challenge. And this is where I think sometimes having the capacity to acknowledge our humanness and that, this is a part of life, and have some compassion can be really helpful in terms of taking subsequent steps. This, I think, is a great video. I'll allow you to watch this separately if you're interested. This was filmed, kind of created by a medical student at the University of Michigan, with several colleagues helping in terms of the experience of having depression as a medical trainee or physician, and just sharing that openly here in terms of hopefully reducing stigma and the anxiety about vulnerability that comes in going through this process. So in terms of other steps, more external tools, a few ideas. One is addressing external influences. So often when we're depressed, our energy reserves, our internal resources are low, and we already may have a lot of demands upon our shoulders, a lot of commitments. So I think it can be valuable to take a bit of a step back and honestly evaluate, are there things that we can say no to create space? And maybe that feels hard at work, but maybe we can say no to taking on extra work. Maybe we can say no to additional external obligations that feel more difficult. And where can you say yes to self-care and connection? Where can you say yes to making time to meet with a family member or a friend who provides a positive influence for you? Where can you say yes to scheduling a wellness day or doing other things that you might need to create space for yourself? In terms of internal stressors, and this is where sometimes therapy, coaching, other programming can be helpful, but just continuing to work on the awareness of what our thoughts are. Generally, when people are depressed, they have more negative thought patterns, but sometimes it can be chicken or the egg, where the negative thoughts also keep driving the depression. So awareness of kind of self-defeating talk or self-criticism, or nothing I do works out, I'm always letting people down. Kind of blanket statements like that can bring us down, to develop an awareness and hopefully turn to with more kindness, more compassion, And again, just thinking about as we take care of some of our thoughts and expectations, that can go a ways in terms of shifting our mindset. So we talked about the thoughts. Some people choose to prioritize intentionality around their nutritional intake, eating healthy foods, eating more consistently, getting enough protein, getting enough hydration, trying to maximize sleep as possible through a resident or physician workload. Incorporating activity, which doesn't necessarily need to be intense exercise, but walking, yoga, or more exercise if that's what really helps someone alleviate some of their distress. And then other habits that we can do. So where can we incorporate mindfulness? Where can we be thoughtful about taking 5 minutes to do something for ourselves during the day? There is good evidence about mindfulness-based interventions for physicians and for people in general in terms of depression and anxiety. And then looking towards support. So either in our inner circle of family, friends, colleagues, or looking externally for more professional help. So there's good evidence about the utilization of therapy in depression treatment, especially in terms of the efficacy, efficiency of treatment. Coaching for some physicians has a different energy, and that can also be a space to work on depression. Medication certainly can be helpful for a lot of people, especially if they have a history of other mental health conditions, family history, or just more severe symptoms. And then we talked about diet, but for some supplements such as vitamin D, omega-3, fish oils, there are a variety of supplements that have also been linked with an improvement in mood. And then really thinking about time away and where sometimes do we just need to carve space to decompress and work on the care that we need. Okay. So if you are depressed, think you're depressed, worried about someone else, what are the resources locally? So I've shared those here. Through the UNM Office of Professional Wellbeing, we have a website. The address follows in the next slide. There you can find a self-assessment tool called an ISP that can be a very helpful first step in terms of kind of getting more direct feedback about the level of depression or anxiety you may have. The score from that self-assessment actually is anonymously sent to one of our psychologists, and if someone is scoring high enough, the psychologist will reach back out, again through an anonymous channel, to say, are you interested in more help? If you respond, at that point anonymity would not be continued, but this is one way to get a better barometer of where you're at and also potentially connect with one of our mental health professionals. We have a list of additional mental health resources. We also have the list for crisis interventions, so crisis hotline, our psych emergency services for people in more acute distress. And then thinking about reaching out, so whether it's colleagues, if it's connecting with someone in your program, faculty, or program leadership-wise who you trust, about where you're at, and that maybe you need to have some support in getting more consistent time to be able to go to therapy, other kind of accommodations, or just mentorship that could be helpful. So here, please find the resources both at UNM, the Office of Wellbeing, and GME Wellbeing resources. I've also included here nationally the ACGME Wellbeing page and the Well website. And I certainly welcome any questions or feedback, both directly to our Office of Wellbeing account and to myself directly. So I just want to thank you again so much for making time to join. Please see some of the other lectures in this well-being series, and I hope that this has helped you just reflect a bit in terms of the experience of depression that individuals go through, why we're at higher risk as physicians, and some strategies to think about in terms of taking care of ourselves and reaching out for more help subsequently. Take care of yourself. I'll look forward to seeing you soon. Thank you.